Okay, Japan, you can go.
Okay.
Hello.
Sensei, we cannot hear you.
Oh.
Uh,
Okay. Can you hear
Japan,
me?
you can go. Yes, we can hear you.
Okay.
Ogura Sensei?
Okay. Hi, Anthony. Okay. Now.
Okay, move,
Nice to
Japan,
see
you
you.
can go.
Hello, Anthony.
Hi, can you hear me?
Yes, you're on. Good morning.
Good morning.
Good
Hello.
morning.
So I'm waiting for Ogura.
Hi.
So can we have your case presentation?
Okay. So, please, my slide. Okay. This patient was complicated with obstructive jaundice, 76 years old male. So according to CT image, pancreatic head tumor was observed. Also, biliary tract was dilated. So after EUS FNA, adenocarcinoma was obtained. So therefore, we tried to insert the duodenoscope into the duodenum. However, because of duodenal obstruction, biliary cannulation was failed. So next slide. So this is a CT image. As you can see, the biliary tract is dilated, and also pancreatic head tumor was observed. So today, I'd like to show my procedure regarding US guided antegrade stenting combined with hepatic gastrostomy. So, because to obtain stent longer patency in my hospital, usually I try to insert the antegrade stenting before hepatic gastrostomy. Okay, please show the EUS image.
L'ordine.
Okay, so we already inserted that EUS scope into the stomach. So as you can see, the biliary tract is nicely dilated. However, as you can see here, debris is observed. So I use today EUME3 is used. So this image has a low echo reduction. So after low echo reduction, biliary tract is clearly observed. So during USBD, low echo reduction may be useful. Okay, so please follow. Okay. Okay,
So
scope.
Dr. Ogura, is
Yeah.
the duodenum free? Is the duodenum free
Yes,
or
we
is there any
can. Yes.
obstruction or?
Okay. We can access the duodenum, but because duodenal obstruction is observed between bulb and anterior obfata. So if your CDS is performed, reflux cholangitis may be frequently observed. So I would like to choose the US HGS.
Okay.
Okay. Okay, so now we already insert the FNA needle using Olympus Easy Shot 3 Plus. Okay, so we try to insert puncture the biliary tract. So using a color Doppler, there were no internal blood cells. Okay. Okay, as you can see here. Okay.
Takeshi, can you just comment on what segment are you choosing and what the reason is behind that? Is it segment 2, segment 3?
Yes.
How do you decide?
Okay, we usually select the B3 because B2 puncture may be easy to insert the guide wire, but as you know, transesophageal puncture can be complicated. So to prevent mediastinum, I'd like to recommend to puncture the B3. Okay, so we puncture the, okay. Okay, so remove the starlet.
So, Ogura-sensei, which guide wire are you going to use?
J-wire is only available in Japan.
J-wire. So is it
J-wire.
angle tip?
Very
Angulated?
yes, angle tip, and also very soft angle. マジか。
Is the J wire monofilament wire? Is there a risk of stripping as you advance the wire?
Sorry?
Is it a monofilament wire? Is there a risk of stripping as you advance the wire through your needle?
No. Okay. Very aspiration. Okay. So okay. Next we insert the contrast medium. Okay, フロロ。もっと打って。So, okay. So you usually injected the contrast medium before obtaining left hepatic bile ducts. Okay, next we insert the guide wire. Okay. Okay,
So
we
what size is this guide wire? 025 or 035?
2.5-inch guide wire.
025.
Okay, so as you know, lever impaction techniques may be useful, but physician-controlled guide wire techniques is also useful. Please up the temoto. Okay, so this is physician-controlled guide wire techniques. Okay, EUS image. Okay, フロロ。フロロに変えて。
The wire looks very soft.
Yes, because loop techniques may be also useful. This guide wire is easily make the loop like this. And then we successfully insert the guide wire. Oh, okay.
Very nice.
So because today I'd like to perform the antegrade stenting. So we next insert the ERCP catheters. We try to insert. Okay.
Okay. So which ERCP catheter are you going to use?
MTW.
MTW,
Yeah.
is it? Okay.
出して投資 X-ray 山間のレントゲンas you know, as you can see, the angle between left hepatic bile duct and B3 is relatively acute. So antegrade stenting may be challenging. But we try to antegrade stenting. Okay, next ERCP catheters will be inserted.
Hello, Takeshi.
Hi. Good
Hi,
morning.
Alberto. Hi. So in this patient, why do you do two approaches? So you do antegrade and the hepatogastrostomy instead of doing one?
Yes, because he's relatively young. Also, he will underwent Forfinox. Therefore, to prevent biliary obstruction, to obtain stent longer patency, I chose antegrade stenting combined with hepatic gastrostomy.
Okay.
Furoro. Okay, next we insert the caster. Heater.
So what stents do you use for antegrade and which one for hepatogastrostomy?
Okay, so I would like to recommend to use laser cut type stent because to prevent stent misplacement. So today I will deploy the Zilver 635. 弾いてる? Oh, very strong. So this patient is frequently cholangitis was of experience. So biliary tract is relatively hard. But we successfully insert the catheters. Okay. Okay. After bile juice aspiration, we insert the contrast medium. ちょっと単純に吸引して。
So just tell us the aspiration of bile. What is the intent of that? Is that for culture? Is that for further cytology? What do you need it for?
Okay, to prevent cholangitis after contrast medium injection. So usually 20 ml was aspirated. Also 20 contrast medium, 10 contrast medium was injected. 20 ml. Okay. Okay. Next we insert the contrast medium. Okay. Oh. Okay, as you can see, the lower common margin. We fortunately advanced guide wire into the duodenum. Okay, so change. We change the position of guide wire. 画面ちょっと下。
So you want to advance the wires far down the duodenum as possible to provide you with a stable position. Is that your intention?
Yeah, saddle power. いるで。
Beautiful.
画面下。コントラストメディウム Okay, right wire is subpart.
Yeah. So now the tip is in the duodenum. So
Okay. So because obstruction site around here, so we try to deploy the laser cut type medicine and transpapillary stent. Okay, so we exchange guide wire. Okay. Also to prevent viral leakage, usually we inject the contrast medium around here. Okay, aspirate. So this patient's stomach wall is very hard. So first we try to insert the Zilver 635, but if failed, we try to dilate the stomach wall using 4 ml balloon catheters. Okay, 上げて、18. So we deploy the uncovered metal stent, 10 mm diameter and 8 mm length. Okay, exchange. That's it. Okay.
I think you made a very important point regarding the risk of cholangitis if you decide to place a choledochoduodenostomy in the presence of a gastric outlet obstruction. So can you just take us through the reasoning there? Is the level of the obstruction important? If it's a type 1, type 2 or type 3 duodenal obstruction, does that influence your decision making in any way?
Yeah. So if type 2 biliary duodenal obstruction may be influence for stent patency for cortical duodenostomy. So, but that's it, Toshi. Okay. But according to our previous analysis, compared with duodenal obstruction, compared with EUCDS, stent patency may be longer in なんだヘパティコガス。So, but this bile duct wall is very hard. So, firstly, we try to dilate the balloon catheters. But if the 硬いねここ。硬いね。ダブルパンクさんとかな。よ。Okay. Oh, exchange. Balloon. 4 mil balloon.
The patient does not have a gastric outlet obstruction, does he?
Yeah. But this patient was not experienced to history of vomiting. But the scope cannot be inserted into the ampulla of water. So we don't deploy the duodenal stent. But if this patient will complicate with duodenal obstruction in your future, I would like to perform the EUS GJ.
But I think that is also why it's very important that you release your antegrade stent distally to the duodenal obstruction. I think that's a very important point that you made.
Okay, direct. So you don't deploy the antegrade stent combined with hepatogastomy in your clinical practice? How about Anthony?
Yeah, so actually if the patient has a duodenal obstruction, we may actually perform both at the same time because after the HGGS, the bowel drain into the stomach, it may cause vomiting. So actually in our experience, we may actually do it at the same time.
Yeah, I think it's a very important point, Anthony, that you need to really strongly consider performing an EUS-guided gastroenterostomy as well in patients where there's a concomitant biliary and duodenal obstruction, because there's a high risk of cholangitis in these patients, and the benefit, especially if you're going to perform a hepaticogastrostomy, the benefit is really determined if the gastric outlet is open.
Okay, we now dilate the tract for biliary tract and stomach wall. So we deploy the antegrade stenting.
Anthony, can you just comment your beautiful study in gastro recently using EUS-guided EUS-guided choledochoduodenostomy? Would you have preferred this in this case? How would you have gone about?
Yeah, so I think for that study we were comparing ERCP versus CDS. So in that situation, it seems that both ERCP and CDS have a similar patency, but CDS was much easier to perform and associated with higher technical success. In this patient with a suspected duodenal obstruction, however, of course, we need to see if CDS is possible or not. Sometimes in some patients where the duodenum is very thickened, then CDS may not be possible. And in this situation, I think the comparison is between CDS versus HGS. So I think Ogura Sensei has done a study comparing CDS versus HGS in the past, and he showed that CDS was associated with more recurrent cholangitis in patients with gastric outlet obstruction. So, however, nowadays we are performing GJ as well. So, in the use of GJ, maybe the difference may not be so significant as well. So, actually, in the era of GJ, I think probably we need to compare the patency of CDS versus AGS again. So, Ogura Sensei, you ready?
Okay. Can I do continue my procedure?
Yes.
Okay. Let us. Okay, we
Please continue.
already insert
Yes.
the standard delivery system. Okay, slightly, gently release the standard delivery system. Okay, release, and then we pull the standard delivery system. This is the ampula. Okay, so standard deploy is successfully performed. Okay, so
Beautiful.
next we insert the wait. Okay, exchange. So next we deploy the HGS stand. So
So the
okay,
which stance do you use for AGS? The Taiwan?
Teum spring stopper is provided by Teum Medical.
By?
Teum, Teum Medical.
So you are using a new stand, right? So it's a special design stand with a
Yes,
anti-migratory
yes.
design in the stomach
So
side.
in proximal
Called the
side,
spring stopper, right?
anti
Spring
migration
stopper.
system is provided.
Is produced in Japan?
Yeah,
Okay.
I
Can you
will
show
write.
us the look of the stomach side for the stand? Do you have the box?
Okay, go. That's the Toshi. Okay, we insert the standard bar system.
Mm-hmm.
So you would never be able to perform this procedure without a trained assistant, right? Because this is really a very
Yes.
complicated procedure where you really need to be in contact with your assistant. Who
Yes, yes.
you actually precede your mind, no? You can read your mind and knows already what you want.
Yes. So in Japan, all experienced doctors will assist you. So this he's a very skillful assistant. Also, one background. He's also experienced. So we can all perform the EUS HGS, but there we are experienced over 100 cases HGS.
So
So
they are nurses.
no, all doctors.
All doctors.
Nurse
So it's
were
so you train the doctors to help you out, so then they will be able to do the procedure because they basically they learn all the passage of the procedure, so it's going to be much easier for them to perform the procedure in the future. Correct?
yeah, right. Okay. So Furoro. Then we already insert the standard delivery system. But during pushing the standard delivery system, echo endoscope is escape away from the hepatic parenchyma. So by doing to obtain adhesion between hepatic parenchyma and stomach wall, after standard delivery system, you should pull the standard delivery system like this. By doing so, we can obtain the adhesion between hepatic parenchyma and the stomach wall. And then to prevent focal cholangitis for B2, anchor band site is placed as shown fluoroscopic image. Okay, please go. Okay, distal side is a very appropriate here. Okay, go. And then continuously stent to release is performed up to 4 or 5 cm
Yeah.
in echo endoscope. Go. Right around here. Okay. And then we switch the endoscopy view. 内視鏡画面。 Okay, and then we perform the down angle, and then push the stent delivery system foot side like this, and then stent release is completely performed like this. So this is a spring stopper. As you can see, the lumen opposing metal stent like here. Okay. This is a lumen opposing metal stent. So this anchoring will be prevent stent migration. So after this procedure, we have no stent migration experience. Okay.
Thank you. Very nice procedure.
Thank you.
So this stent is produced by which company?
Teo Medical provided produced by Isayama.
Oh.
Oh. So Anthony, Professor Anthony,
Yes.
this stent is not still available in Hong Kong.
Not yet, I think. So in Hong Kong, we have the Spexis HGS and also the hot geoball.
Oh, good. But we cannot use the lumen opposing metal stent for cortical duodenostomy. So all many Japanese endoscopists like this procedure compared with EUS series.
I see.
Do you ever place a double pigtail stent into your hepaticogastrostomy stent?
No. So
as a secure, never.
This stent is similar to geobal stent. Therefore, during plastic stent insertion, stent dislocation or migration will be complicated. So I think plastic stent deployment into the HGS stent is not needed. Indeed, we have no experience stent migration into the abdominal cavity.
Takeshi, can you also comment in patients that are potentially resectable, but where ERCP has failed? What technique would you propose, or what technique would you favor in that setting?
In operable cases?
Yes, or patients that may become operable. So does that alter your management? Do you have a preference in that setting?
Yes. So in my opinion, EUS HGS is better, but surgeons recommend to do the EUS CDS using hot axios, but we cannot use hot axios. Therefore, surgeons agree with standard deploy. EUS HGS is agreed.
Have you had cases of seeding due to spillage of?
Yes, I have. I think also tumor seeding, risk of tumor seeding. But we have no experience tumor seeding after EUS HGS before surgery.
Yes, we've got one question specifically asking if pancreatitis is a risk in patients where this procedure is performed.
Antegrade stenting?
Yes.
Yes. So antegrade stenting is recommended to above the papilla. But if pancreatic head cancer, pancreatic atrophy is complicated. So antegrade stent deployment, even if antegrade stent deployment, pancreatitis may not occur. But cholangiocarcinoma or gastric cancer, antegrade stent deployment transpapillary, acute pancreatitis can be easily complicated. So such cases, I don't deploy the antegrade stent, only HGS.
Okay, Anthony, do you have some additional questions or comments?
No more. Thank you.
Thank you.
Yeah, this was a wonderful procedure. It was performed
Absolutely.
excellently.
Thank you so
so
much.
much. We
Thank you,
are a bit
Takeshi.
ahead of time. Alberto, I'm not sure if there are any more questions that we can ask. How much time do we still need before the next case?
We are a little bit ahead. I have to see if Sandeep from India is connected or not.
So maybe we can ask Anthony in the meantime. Anthony, what do you think is the next study to be performed?
Actually, our study comparing EUS gastroenterostomy versus duodenostat has been accepted.